the opposite was discovered. The patients who went into the study with the smallest end diastolic volume index were the ones who did better, which doesn't make any sense. And perhaps it's complicated, in fact, by the issue that there were 500 patients done at 127 clinical sites in 26 countries. And some of these numbers are very low. So perhaps this was a very heterogeneously treated group of patients, but I think we have some of the answers. Now, what were some of the other issues regarding therapies for heart failure and preserved ventricular function? Neurohormonal blockade was significantly a topic, and different interactions, and there's several trials ongoing right now that will have results probably within a year about whether or not neurohormonal blockade is going to improve patients with heart failure, although medical management of heart failure has dramatically improved over the last 3 to 4 years with medical management and other issues. Also, aldosterone antagonist therapy, the TOPCAT trial is ongoing, and prostaglandin PDE5 inhibition with sildenafil is also a trial ongoing, and the data on that so far is looking good, that patients with secondary pulmonary hypertension, who are heart failure patients, who are treated with sildenafil, actually improve their VO2s, their exercise capacity. So we have some hard evidence, and those trials are ongoing. Also significantly is the fact that we have ventricular assist device therapy that has gone quantum leaps better from where we were a few years ago, and I see you have a great session scheduled tomorrow on some of these issues, surgical management of heart failure. But some of the new axial flow pumps have just been a huge benefit for patients. So that's another issue in terms of the heart failure patients, and there were several sessions talking about when to consider a mechanical device for a patient, when to consider RV, LV function issues, and will the RV survive if you're going to put just an LV support in. Congenital cardiology solutions was a very well-run group of sessions led by Michelle Gerberts, and they had for this year's first McNamara lecture an inaugural speech by Dr. Mullins, who is a pioneer in pediatric cardiology, as many of you are aware. Now, they had some very interesting sessions this year, and they were looking at several issues, including quality improvement initiatives, which is something we're all interested in. And I was very interested to hear the lecture here about the Gulf registry that you're running in this region. I think that's phenomenal, because looking at the data, no matter where you are in that spectrum of the data, helps you improve the data. And it doesn't necessarily mean that you're doing something wrong. It means perhaps we can do something better, and we learn from each other. And so the pediatric teams have devoted and launched a very significant quality index measure event. And there were several international collaborative sessions that they gave, and I'll talk a little bit about the QI effort that they're talking about. We had numerous oral sessions in this group. There were several spotlight sections, as we had in the other, and we tried very much this year to have some debate sessions. We find that the audience stays awake more if we have a controversial conversation where there is evidence for both sides, and have a spirited debate. And we had several spirited debates this year that were very well attended and were very instructive. Some of the things that they talked about in terms of really eye-opening, it was fetal intervention. It's no longer something that's being talked about just experimentally. It's being done in a major way. ICU management is a big issue, and how to standardize that, especially if you have a small pediatric unit. Hospital-to-home transition is something that has been lost in the shuffle, but has been something that has been very big in improving morbidity for patients who had congenital heart disease. And some very innovative things have been developed by nurses, nurse practitioners, and clinical care associates. And we've seen some wonderful models developed that have decreased problems of readmission and have improved survival dramatically. And it's key for education about this, because for all of us, because there are now a huge number of patients who survive congenital disease with wonderful treatments in neonatal and early childhood years who are now adults with congenital disease. And there's a burgeoning need for management of these congenital patients. And some of the interesting things that came out, some key learning points that came out, were that cardiac MRI for ascending aorta is a very important study to do if it's a bileaflet aortic valve, with all the controversy about aortic dysfunction, aortic mechanical wall abnormalities in patients with bicuspid leaflets. And transthoracic echo is a simple test for just managing patients with tetralogy for RV volumes. And here are some interesting images that show a fetal aortic, a fetal intervention to take a child with basically hypoplastic left heart syndrome, and with fetal intervention, go ahead and give them a biventricular outflow. And they had actually a single center presented 76 fetal interventions with 5-year follow-up, and compared it to their standard therapy, and it turned out those who had fetal intervention had much improved mortality compared to the standard hypoplastic left heart management, which is complex, as you are aware. So that's a landmark presentation. In terms of the echocardiography issue, this just re-emphasizes the need to do something other than just an echo in a young person especially, but probably adults as well, who have a bicuspid aortic valve, because we're knowing increasingly that a substantial portion of patients with bicuspid aortic valves have aortic pathology and are at risk for other calamities like aortic dissection down the line. And this is an example of a child who had an aortic valve with an aortic root dimension read on a transthoracic echo as not abnormal. And this is the child's MRI, because the echo windows weren't so great. And this child actually had a 5-centimeter ascending aorta. And so this was their landmark point to make, that we really need to do something differently for people with bicuspid aortic valves. And cardiac MRI will probably be added to the recommendations guidelines. Now, this was a very interesting quality improvement assessment event. 32 pediatric hospitals, this was a presentation 3 weeks ago, looked at a combined total of 11,284 complex, that's not ASD repairs, complex congenital procedures. And the goal was to look at patterns of quality outcomes. And they looked at things like death, morbidity like stroke, length of stay. But the simplest thing to look at is mortality. And they wanted to look at volume and mortality. And what they discovered is, surprisingly, volume was not a complete surrogate for quality, and that there were a high variability in variabilities. And now they're digging down into this a bit further. But just their looking at this is going to improve their outcomes, which again is why it's so critical to have data, because you learn when you start to fine-tooth comb things. Excuse me. Sorry, I'm with a little bit of a dry voice. Now, I'm very pleased to go ahead and give the I2 sessions next. Unfortunately, George Angus, who really wanted to be here and was looking forward to this quite a bit, had a family medical emergency. And I'm going to try to stand in for him, although I could not do the I2 justice like he could, but I'm going to give it a try. If we can switch that slide bank, please. And I'm sorry to be going over so much so quickly, but I know it's been a long day, and I greatly appreciate your attention. So the ACC I2 2010 highlights, excuse me, were quite interesting, and I am only going over the ones that I thought were really key, and George picked a lot of these out as well. This was the angiojet rheolytic thrombectomy before direct infarct artery stenting, with direct stenting alone in patients with acute MI. This was a great trial. This was 500 patients, and they randomized them to either go and have standard drug-eluting stent therapy if they were qualified for that therapy, or they got a rheolytic thrombectomy and a drug-eluting stent. And let's see what happens to those patients. At 6 months outcome, the patients who got the jet stent actually had lower death, lower MIs, lower rates of revascularization of the target vessel, and total lower MACE. And this also held up, thank you. This also held up out to almost a year, and the events continued to be much lower in those who got the rheolytic therapy. And those of you who may know this, pardon me, it's not a cheap device. And obviously we're all in an era when we have to do things where we have to justify, why are we asking for another gizmo? The administrator said, you just asked for this other thing last year, and now you're not using that.